All righty, let's go ahead and get started. Hi, everyone. Welcome. I'm Catherine Bowles. I'm a professor of nursing at the University of Pennsylvania School of Nursing. I'm pleased to be hosting this webinar today. I'm also a co-director of the Healthy Aging Corps for the NIA-funded Penn AI Tech Collaboratory. So welcome to our webinar series. Penn AI Tech is the Penn Artificial Intelligence and Technology Collaboratory for Healthy Aging. And it's an initiative at the University of Pennsylvania, funded by the National Institute of Aging. Penn AI Tech promotes the design and innovation promotes the design of innovative technology and artificial intelligence methods and software to support older adults and those with Alzheimer's disease and related dementias in their home and environment. So today it's my pleasure to welcome Dr. Barr to speak to us about ambient clinic visit recording and AI in older adults. Dr. Barr is an associate professor at the Dartmouth Institute for Health Policy and Clinical Practice, Biomedical Data Science, and at the Center for Technology and Behavioral Health. He's a member of that center at the Geisel School of Medicine. And Dr. Barr is trained in quantitative and qualitative methods, and his research agenda has been funded by multiple institutes at the National Institute of Health, as well as PCORI and other foundations. A well-rounded investigator for sure. Dr. Barr leads the www.openrecordings.org. It's a multidisciplinary group of researchers, patients, caregivers, and doctors working together to understand how to improve the communication of clinic visit information. They are particularly interested in the use of audio and video recordings of clinic visits to support the communication and AI-related applications based on those recordings. Dr. Barr's research portfolio also includes the development and implementation of shared decision-making interventions and measures within a program called Collaborate. So before I turn over to the speaker, I just want to remind the audience that this talk is being recorded, and you may use the Q&A area to post questions throughout the talk. But we're going to wait until the end of the session to cover those questions. So without further ado, I'd like to welcome Dr. Barr to go ahead and begin his talk. Thank you.
Thank you so much, Professor Bowles. I really appreciate the invitation and the opportunity to come and speak to you all about the work that my team's been doing, and truly is a team effort. All of this work, nothing's possible without a team. As you can tell, I'm not originally from the Upper Valley in New Hampshire. I'm from Ireland, and I've been living up here for 14 years. And one thing I want to say is just like how pleased I am to come and speak to a School of Nursing. My mum's a nurse, and I truly believe nurses are the most important, yet unfortunately undervalued healthcare professionals. And to all the nurses in the seminar, thank you so much for everything that you do for our patients. So I will jump in, and I'd first of all want to, acknowledge the different funders that have supported the work that I have, the patients, families, and clinicians who make the work meaningful and possible. My many teammates who support this work and make me all the happier for coming to work every day. And yeah, I will move on. And I have no conflicts of interest to declare. Okay, well, in March 2023, Professor Peter Lee, the Corporate Vice Chair, President of Microsoft Research, had predicted that all of our visits would be recorded within the next 5 years. And when I heard him speak about this on this NEJMAI podcast, it really didn't surprise me or our team, because back in 2018, we had conducted a national survey where we had asked patients and clinicians whether they had ever recorded visits to share them with patients to take home and listen back to in order to try to manage their care. And what we found was that almost 30% of clinicians had a visit recorded and given to a patient to take home to listen back to. And according to Berwick's diffusion of innovation theory, dissemination of innovations in healthcare has a tipping point of about 15 to 20%, after which it's really difficult to stop. So, it wasn't a surprise for us to see this happening and emerging. I think what was surprising, as you'll see over the course of this talk, was just that it took as long as it did to emerge. And really the main reason for this massive growth and interest in recording of clinic visits is the result of large language models and all the benefits they can bring, but we'll also talk about some of the risks and the harms that are also perceivable with the use of these tools. So I'm going to give you a whirlwind tour on how we got here. I'm going to first talk about recording generally and the literature around that topic, some of the work that we do in this area, and then I'll move into AI applications for older adults where we can use visit recordings and some of the ethical dilemmas that will raise. So how do we get here? The most trusted source of medical information for our patients, for our older adults and their care partners, continues to be the clinician. Despite the emergence of GPT and Google and all these other technologies and forums folks can use, this is still where they want to go for their healthcare. And in the US, our older adults have around 1 billion healthcare office visits per year. That's a staggering number of healthcare visits. And within those visits, incredibly important and meaningful information is shared between the patient and their clinician, but that information is then used in the community where the older adult has to manage their care and actually care for themselves and have their family support them with this care when necessary. The issue though at hand is that there's a lot of information to remember. And let's think about some of those tasks and things that they do have to remember to do in order to fulfill this care outside in the community. So, you know, they have to be able to fill their medicines, they have to self-administer complex medicine regimens, they have to arrange their appointments, they have to pay their bills, they have to inform their family of what happened in the clinic visit, they have to use medical devices, they have to train their loved ones or assist them or on how to use these medical devices, they have to monitor their symptoms, they report this all back to the clinician, and all of this while living with their medical condition. That is a lot of work and a lot to remember. Yeah, we know up to 80% of visit information is forgotten when folks leave the visit. And that's not just with older adults, that's kind of across the board. We tend to forget a lot of the meaningful information. And this is compounded for older adults as we age. It becomes more difficult for us to really process that information quickly and remember it when we leave the visit. And we also tend to deal with more complex medical issues. This results in reduced patient quality of life and worse health outcomes. And it also has a financial impact. When we can't remember this information, it can cost up to $300 billion in avoidable healthcare costs that are attributed to non-adherence to medical advice. There's also a significant impact on our care partners. So many of our older adults have care partners who help support them with their care, and there's up to 50 million care partners in the US. These are typically unpaid family members or friends. Of that group, 84% report that they don't have enough information to help support their loved one with their care, and this can cause a lot of anxiety and stress and exacerbate health conditions for these people as well. Now, there's many different ways we've identified to try to help support people remember and take this information back from the visit. These are some examples. In the US, we have the after visit summary that's been around since meaningful use, around 2010. And that's a summary of the visit information conversation, that we have around the diagnosis, a few lines on what was discussed, the medications maybe. They have a similar thing in the NHS. I had a talk with that group not too long ago, where patients can get access to an after visit summary like this. And then since 2021 in the US, we have access to our patient portals where we can actually go and read the real notes that clinicians have made. So this is a real boon for transparency, and patients do find this helpful. However, there are challenges with this, and we don't know if it's really the most optimal way of sharing information. We have learned from our work, and others have reported that these health portals aren't specifically designed for patients. And so when folks read the information in them, they often get quite confused about what it is they're actually trying to communicate. This is a quote from one of our patient partners. These are patients who work with our research team. When you get the after visit summary report, it's like watching a program with half of it missing. They don't consider it comprehensive and they find it difficult to understand. A way to augment this information is to share clinic visit recordings, and that started to emerge, I guess, over the last 10 years, but there's actually a wealth of research over the last 30 to 40 years on this topic. Recordings are a comprehensive record of everything that was discussed. And we will argue are potentially a really valuable way for patients to help manage their care when they go home. Excuse me. There's been a number of studies of this over the years, And there's been systematic reviews of those studies. Now, most recently, there was a study of what is added value for patients over the age of 50 years of age of sharing visit recordings. That actual study, the review started with an age band of 65 or older, but there was so little research they had to drop it to 50 or older. So what do we find in terms of the potential benefit of sharing recordings with patients? Well, what we find is that people listen to the recordings. They've actually logged in and listened back. Up to 72% of people listen and listen more than once. It results in greater recall and understanding of medical information. Patients seem highly satisfied with this information when they get access to the visit recording. Care partners report listening back and accessing the recordings with the patients. And they also report that there seems to be a reduction in anxiety related to supporting the patient with their care. We've started to see improved mental health outcomes, both in our own research and in others' research. There's some signals that when people have access to this fuller set of information, that does improve their mental health. And there's reports also that during the clinic visit, when a recording's happening, there's a sense of greater accountability on the clinician's end, which they feel improves the quality of their communication with their patient. An interesting finding that we have observed over our research, and we have studied clinic visit recording for a decade now. Patients, when we ask them, what do you do when you listen to the recording? What's the value for you? One thing we'll hear is that they want to listen back to the information that was discussed. It's really important, and they want to be sure to remember it and to act on it. Equally important, though, which was really surprising to me when I first heard this, was that they evaluate their own performance in the visit. Was I a good patient? Did I tell the doctor everything? Was there anything I forgot? And care partners do a similar thing when they listen back to their recordings as well. We also find in some smaller studies that there could be a reduction in patient phone calls to the clinic because they have access to the recording to listen back to, so they don't need to call. So we mentioned my research team up in recordings. We've been conducting a number of studies to try to really expand in this area of work. Much of the prior work has focused on a single recording of a visit, often in cancer care, where it's really valuable research, of course. But what our team was interested in was, well, what if we routinely recorded visits and shared those with patients as part of standard care? And what if we did this in primary care with older adults who have to manage a lot of different conditions and complex medicine regimens? So we developed some technology to support this. I'm not going to spend a lot of time talking about this technology specifically, but we did develop a tool called HealthPal, a health personal audio library. And we use this tool in all of our different clinical trials to record visits securely and allow patients then to listen back to them when they go home. They can make notes on the recording, they can share it with a loved one. And we also have a more sort of all bells and whistles version of this that uses different AI-powered features to curate the visit recording, which I'll tell you about later on. For any junior folks listening to this call, it's just a point of the importance of pilot studies. And so I'll talk about some of the larger trials in a second, but these two projects here, the audio trial and our video trial, were really linchpins to get these bigger projects. In our audio trial, we conducted a pilot study across 3 sites at Vanderbilt University Medical Center, at Dartmouth Health, and at University of Texas Medical Branch in Galveston, where we randomized older adults in primary care to receive access to visit recordings for 3 months or to receive usual care. And what we found was that we hit our recruitment number. We recruit these 90 people. 85% logged in and listened to their recordings. Now, we certainly experienced some ageism in reviewer comments when we would submit our grants because they said older adults would likely not use this sort of technology. And I think that's good evidence to show that actually that is not the case and they really enjoyed using this technology. And we also, even though we weren't powered, found improvements in mental health in 3 months for older adults who had access to recordings. In our video trial, we did a randomized controlled trial with 24 people living with ALS, where we video recorded their multidisciplinary clinic visits. These are 3 to 5 hour long visits. They have typically every 3 months, where these patients will meet with up to 12 specialists. And, this is a terminal condition with really complex management. And what we found here was that people were really excited to get access to the recordings. They would really watch back a lot their occupational therapy, their physical therapy, their neurology visits. And again, another interesting observation was that 50% of our patients passed on this project, given the nature of the condition. Many of the care partners would look back in and keep watching the videos. And so we're interested in the potential for this to be a bereavement tool. What this points to is a bigger issue that I think in healthcare, we have this fallacy in our minds that the important thing is simply the transaction of medical information between the patient and the clinician. But there's so much more in the visit. And so you can see some of these quotes that we have for some of our research projects. One here at the top, this is a patient in primary care, an older adult, and their husband who had cognitive deficits. And they would record their primary care visits, and they would say they would listen back, and together they would form a full brain and would be able to stay on top of their lives. That's such a beautiful quote. I can remember vividly having this conversation with this dyad back in 2016. And when I mentioned about it being more than a transaction for medical information, the quote in the bottom left here, it's like my right hand that I can go back and forth with. I play it back and forth when I'm down in the dumps. This was a patient who had stage 4 cancer. It was terminal. We weren't even too sure if we should be interviewing them, but they really insisted upon being interviewed because they used recordings routinely in their cancer center. And the person would listen to the jokes and the little bits of good news they would get during a visit, even though they had this terminal illness, and that would bring them some relief. And when they would get home, they don't want to tell their family every time when they ask, well, how did the visit go? They don't want to keep talking about the fact that they're dying, so they would give them the recording to listen back to. These are maybe some sort of outlier cases, but it just shows the potential value beyond, a 2-line summary of what was discussed in a visit. So these projects led on to these larger trials that we're conducting, which again, I won't spend too much time on, but we're really pleased with how they're going. So this is an R01 called Replay, funded by the National Institute on Aging. It was really an expansion of the audio trial. So we recruited 336 older adults across the 3 sites, and again, randomized to receiving visit recordings for 12 months versus usual care. And we're examining whether or not it improves the ability of older adults to manage their care. And as I speak today, we have our 4 final patients to recruit, which we should have recruited by the end of this month. We'll hit our 336. It points to the hard work of the team that we work with here, but also the interest in older adults in this type of research. Another trial that we have was funded by PCORI. It's working with the same 3 sites. In this case, with PCORI, the Patient-Centered Outcome Research Institute, you have to have comparative effectiveness. So here we wanted to look at whether or not we could just train older adults in how to use their patient portal more optimally. And we've actually found through this work that many older adults aren't really too sure how to use the portal very well. We don't do a good job in health systems of training them. So we train them on how to do this in both study arms. But then in one of the arms, we also give them access to visit audio recordings for 6 months. And we're exploring whether or not there's improvements in quality of life at the end of those 6 months. So in this project, we're aiming to recruit 900 older adults, and we're over 547, so recruitment's going excellent. We're also recruiting care partners, family members or friends who help support loved ones with their care. And we're on target to get around 150 care partners on this project as well. So I can follow up with folks afterward to learn more about these projects, but I just want to highlight the importance and interest in this area. And then finally, in September this past year, 2025, we received funding from PCORI to do an 8-site national clinical trial of video recording and expansion of the work that we've been doing with patients with ALS, where we'll video record those multidisciplinary clinic visits for 12 months and find out whether or not we can improve the folks' quality of life those 12 months. Now, thinking about people with ALS, you may wonder, well, how could you improve their quality of life? It's such a terrible condition. Folks with ALS, they have this response shift where this becomes a new normal and their quality of life kind of steadies out. And we know from the literature that if we can improve how folks adhere to the recommendations from these multidisciplinary clinic visits, they can extend their life by up to 7 months, which is incredibly meaningful to this patient population. Just before I move on, I will mention again about patient partners. In each of these projects, we have a group of patient partners and care partners guiding us in everything we do, from study design to interpretation. So I've covered a lot about the evidence and the interest and the systematic reviews. And so you may wonder, like, why has recording not been commonplace in healthcare? Since we have this evidence now going on 40, almost 50 years actually. Well, one reason was the technology. We used to have recording devices like the top here. No, we now all have recording devices in our pockets with our smartphones. The second thing, though, is that I don't think health systems really truly value the concept of recordings. Sure, it's helpful for patients, but it didn't seem like that was enough for them to really bite on taking this up. What changed is the birth of large language models. And now they exist, we can use these recordings in a number of different ways that are deemed to be highly valuable to health systems, and which may then hopefully result in patients getting access to recordings too. That's still not common. So just as a refresher, I don't think I need to tell this group you guys are interested in AI, but really large language models are predicting the next word in a sentence. I think it's just a very, very, very high level overview. I am not a data scientist. I'm trained in biostatistics and qualitative research, but I work with really wonderful data scientists and I have enough knowledge to get in trouble, but also to know when to stop and ask the experts. So how can we use large language models in this new era of AI, especially with the emergence of ambient visit recording, where our recordings are being made pretty much at scale in the US at this point? Well, the biggest driver was really to try to reduce documentation burden for clinicians, which I'm sure many of you are pretty familiar with at this point. In 2023, it was reported that 53% of clinicians felt burnt out and 23% said they were depressed. And a major driver of that was excessive documentation burden, unfulfilling after-hours documentation. Since ambient recording has come, these ambient scribes, where we record and they write the note for the clinician in the medical record automatically, there seems to be a lot of positive experiences from our clinicians. They feel more satisfied with their work, they feel more engaged during their visits. Patients have reported in some of these smaller studies feeling more engaged. It may reduce after-hours work. So this is one of the earlier studies. There has been more very recent studies. So this was a large one conducted with 5 academic medical centers, just published last month. And they find that people who adopted AI scribes, that they spent 13 minutes less in the EHR and 16 minutes less on documentation over 8 hours for scheduled patient care. And it was particularly helpful for female clinicians, advanced practice clinicians, resident physicians, and primary care medical specialists. Of note, though, what was quite interesting was that there wasn't much of a change in the after hours EHR time that clinicians spent in the medical record. And there wasn't too much of a change in weekly visit volume or cost of care associated with the use of the AI ambient scribes. You'll hear later a concern that I have related to this as this technology emerges and matures. Another benefit is that clinicians feel sort of a greater sense of reduced cognitive burden during these clinic visits. And I would argue that with reduced cognitive burden, the clinician and the patient can reconnect emotionally during the visit and have more deeper conversations. That's the opportunity that's afforded with this technology. Whether we take advantage of that opportunity is another question, which we'll talk about shortly. There are just a cottage industry of ambient AI scribe companies out there, and they're just I've lost count basically, but it's really disseminating at a pace like we've never seen. So if you think about it, the electronic medical record was first kind of brought up and utilized 50 years ago. And it's taken that long, well, probably 60 years ago at this point, it's taken that long for it to become widespread in the US. With the ambient technology, recording technology, it's taken about 5 years. So a concern again is the pace at which this is being implemented. It does open up some questions as to what are the unforeseen consequences of this. Other applications using visit recordings, they can assist with real-time diagnosis and treatment recommendations. I love the name of this paper is Speech the New Blood, but what the authors had argued is that technology, and this is a few years out of date now, but even at that time, they were able to use recordings to predict different respiratory conditions, psychiatric disorders, developmental disorders, neurodegenerative disorders. And the literature is now pretty crammed of projects who are using these types of advanced approaches to assist with diagnosis and making treatment recommendations. When it comes to treatment recommendations, I do a lot of work in shared decision making, and the use of recording in real time to assist with shared decision making is beginning to emerge. It's a pretty nascent field, but I can tell you every conference I go to now, there's at least 4 different separate sessions on AI, and they're crammed to the rafters. We can use these recordings to help patients manage and make more sense of complex health information. And so my own group has developed this AI version of our health pal to really create a library for patients. So our tool, for instance, can take a recording and find key medical information that patients have told us through our co-design. We designed this with older adult patients and their care partners. Information they find important, such as the medical condition. They can find where it was discussed and they can replay that moment again. There's a pop-up screen where they can click on a new medical term and it'll tell them in lay terms what this means. So there's many other features that we're developing into this. And for instance, we have another R01 from the NIA where we are recording 200, where we recorded 200 people living with dementia and their loved ones visiting primary care, and we recorded all of their visits for 12 months. We're analyzing the interpersonal interactions between the patient, the clinician, and the care partner, and how that flows and changes over time, and whether or not those interpersonal processes impact health outcomes and behavior of the patient, clinician, or the care partner. Our goal is to learn from this and then redesign our HealthPal application to target those mechanisms of action that are important in the care of people living with dementia and their loved ones. This has resulted in spin-off projects where my 2 PhD students, Salar Halasadagan and Mora Ansando, are exploring how we can measure uncertainty in clinic visits. Where does uncertainty arise? How is it responded to? And what impact does it have on healthcare? And Mora is interested in microaggressions and the experience of Black patients with dementia and minoritized patients with dementia broadly, and what is the care like that they experience. Another application is around psychotherapy. So we have a project called Audio Care we finished up. We have a grant under review currently as the new project to lead on from this. But we were interested in how we could record and share psychotherapy sessions with people, because if you think about psychotherapy, the words are the medicine. And so when people come to therapy, they may go a week or 2 before seeing the therapist again. And currently they don't get anything to go home with, maybe some homework to do, but they have no way of accessing their medicine because it's not recorded or shared. And so we were interested in whether or not we could record sessions and ask patients to review those sessions and tell us, like, where is the meaningful moments in your therapy? And then the next extension of that is, can we predict those meaningful moments for people? So we recruited 15 patients. We recorded 2 psychotherapy sessions in a row. We had them record or review their therapy sessions. We also had the therapist review the sessions too. And so we could compare what did the patients find meaningful and what did the therapist find meaningful, and are they the same? So, and I won't go into all the details of the methods, that would take too long, but what we found was that there was some nice overlap in areas of interest. We had a psychiatrist and a psychologist create an ontology of psychotherapy. So then we could find if a person highlighted a certain segment of the therapy, we could pretty much say, like, what this is, that this moment in therapy is around validation. A few findings. One is that therapists highlighted a lot more stuff than patients did. Another finding was that while there was overlap with things that were important to both the patient and the therapist and the types of information or the moments in therapy, one thing that was a big difference was social talk. You can see that that was the 3rd most highlighted piece of information by the patient, yet it was right at the bottom of the therapist. When we talked and interviewed our patients, they told us that social talk is really them extending themselves to their therapist, where it's a window into their mindset and it's a way of trying to build rapport and trust. Whereas our therapists are so focused on the protocolized therapy they want to deliver, that's kind of something that falls out of their sort of view. And what this highlights is, if we don't know what's important to our patients in the sessions that we have with them, it's quite difficult for us then to really design ways of communicating this information to them after the fact. We have another project that I haven't shared called Finding the Value, where we did this in primary care and in cancer specialty care. And we had sort of similar findings too. And in terms of prediction for our grant that we had submitted, fingers crossed it gets reviewed in June, we were able to get some reasonable prediction. Certainly not perfect, but not bad. So it's encouraging that we could maybe start finding and predicting these things. And our hope is that then we could share them with patients when we find them through this larger project and evaluate whether or not this improves their care at home. So the kind of one of the final applications I want to talk about is for health systems to evaluate the quality of visits and improve training of our clinicians. There are now a stream of emerging automated strategies to evaluate patient-centered communication, shared decision-making, and other ways of evaluating the performance of clinicians during clinic visits. I have no doubt they will start getting implemented as ambient recording is being pretty widely used. And so some other really fascinating ways of using this. So I work with colleagues at UVM in Vermont, Burlington, led by Professor Bob Gramling. And you should visit their website if this is something of interest. But Bob's group has been trying to really understand deeply palliative care conversations. And they look at these really interesting sort of elements of those visits. So for instance, they've developed technology that you can download and use around finding connectional silences. And these identify silences that are non-connectional, emotional, or invitational. And they've found that by finding these, measuring them, they can see associations when connectional silences are high, where it's allowing patients to process this palliative care conversation, these serious moments, with improved quality of life. They've also been studying whether there's story arcs in clinic visit conversations, like themes, common themes. If you think of Kurt Vonnegut's, like, 7 different types of story arc, they've been looking for similar patterns in these clinic visit conversations on what that says about the visit and whether there's associations between different story arcs and outcomes. Some really groundbreaking, innovative work by Bob and his team. Now, in terms of an application of all this, you could imagine we currently use CAP surveys to, assess the quality of our clinic visit interactions and experience patients have, yet response rates are pretty low, they're around 30% and falling. And these surveys are used to sort of impact clinician reimbursement. So they're pretty important. Ambient recording technology will probably offer a more cost-effective solution to this. Now, that could be a good thing, but it also could result in an unintended consequence and harm, which we're going to get to quite soon. Whew. This is like a unicorn. It feels like we don't have to do anything any longer. We can throw things into GPT and it's going to fix all of healthcare's woes. But I will say it's really, really, really important that we know the limitations of this technology and we don't go in too enamored by it. It's very helpful. It is a movement which we have to better understand, but we also have to really understand the limitations of it in order not to experience harms for our patients and for ourselves. Okay, but one question first, and I'm doing this virtually, so it's difficult, but we'll run with it. How do you confuse artificial intelligence? You ask it to differentiate between a blueberry muffin and a chihuahua. It used to have a really hard time with this. As you can see, there's definitely some similarities here. But when I would give these talks a few years ago, it wasn't very good at it. But then I figured GPT's coming along. I bet you they could do a really good job with this. So I actually asked GPT. I was like, "Hey, here's this image of this blueberry muffin and the chihuahua. Can you tell the difference?" And it, sure enough, gave me the correct answers, like in the chat box. This is the row. This is a muffin. This is a dog. And then it asked, "Would you like me to label the grid for you?" I was like, "Yeah, that would be wonderful." So I tried labeling the grid, and as you can see, it didn't quite get it right. I was like, "Huh, that's interesting. You got it's wrong. Your image is incorrect." It's like, "Oh, I'm so sorry. Let me do it again. I'll get it right this time." It's still not quite right. So I then asked again, like, "Oh, you're still getting it wrong. What's going on?" Then I broke GPT. There was a network error. And so after using the power of probably a small village somewhere, it asked again, like, why are you getting this wrong? And it explained it recreates an image of the original image. It tries to relabel it. This can result in issues. And so it asked, would you like me to annotate the original updated, uploaded meme? I was like, yes, let's do that because I will get it 100% accurate, no question. Still not quite there. So I'll say that, it's a funny example, but I'm not sure AI is completely taken over the world just yet. So, let's like be aware of some of these limitations. And uh, but back to a more serious note, we actually have an ethical obligation to our patients, clinicians, and the public to consider both the opportunities and risks of this technology in healthcare, and we really shouldn't take this lightly. As a scientist with my colleagues engaged in the study of clinic visit conversations, we're enthusiastic about the potential of routine clinic recordings and AI applications that can power and improve the quality of healthcare communication and delivery. But realizing the benefits of routine visit recording requires the prevention and amelioration of unintended foreseeable harms. So let's go through some of those harms together. First of all, added burden of ambient recording technologies for clinicians and patients. So the efficiencies gained from ambient visit recording, where it's writing these notes, doesn't equal productivity from the clinician. So we must be careful not to take the efficiencies from reduced administrative tasks and simply adding more work to clinicians. This is a crude approach that will not reduce the burnout problem. And it threatens the opportunities to enhance communication between patients and clinicians if we just keep filling clinicians' days with more and more patients because the notes are being written for them. Unfortunately, this is exactly what we're seeing emerge in health systems. And this isn't a quirk. This is absolutely by design. The companies that bring out these technologies, this is they say they can add 3 to 5 appointments more to the clinic day for a clinician. That's a little scary for clinical colleagues. And while it can reduce the burden of documentation, generative AI hallucinations are actually pretty common. It sometimes makes up answers that are very convincing but very wrong. And so the problem here is that as humans, we take shortcuts. That's how we think. It's our bound of rationality when we make decisions. But as automation bias creeps into healthcare, we'll start accepting the answers without really questioning them, and they could be very wrong. And so we need to have this meta awareness of what is actually being produced when we're using these tools to assist with diagnosis, treatment decisions, and writing notes. And on a bigger scale, this truly is a risk to the profession of medicine. The reported delegation to intelligent systems leads not to liberation, but to atrophy and irreversible loss of professional know-how as skills go unused and unrefined over time. This cognitive de-skilling is something that we've already started to see emerge. For instance, radiologists, when they use these technologies to support their work, when you remove the technologies, their baseline performance drops below what it was before they started using the technologies. These are serious, serious issues that we have to really try to tackle and challenge to avoid losing this expertise that we have. There's issues of fairness. It's crucial to address the algorithmic biases that frequently and disproportionately affect underrepresented groups of people due to homogeneous, imbalanced, incomplete, or inaccurate or differentially inaccurate training data. For instance, with older adults, 92 publicly available data sets for AI training. Only 24 included any information on age, and there was minimal inclusion, really, if any, of the old 85-year-old adults. Years of systematic bias toward minoritized patients will not allow us to quickly address this issue, and building technologies on the basis of training data that doesn't include older adults could result in exacerbating disparities in care. Another risk is commoditization of the data. So clinical data is required to train algorithms. It's not really widely available to train algorithms yet. This in turn is used in healthcare. So AI makers placing monetary value on clinical training data and health systems placing monetary value on trained algorithms. If either or both of these entities are driven by profit or ownership of IP, this can quickly create circumstances where visit recordings become commodities fueling the development of proprietary AI. And so, we see this could emerge in the wild in different ways. For instance, those technologies that can assist with diagnosis, you could imagine it could be used by an employer or an insurance company where they could get a person's social media and predict the likelihood that this person has a medical condition or is a risk. Real issues. An early application of AI in clinical encounters is to assist with billing, and the latter purpose really requires a clinician's judgment about reasonable representation of their work to maintain compliance with payer rules and federal laws. But we need to avoid machine learning technologies unintentionally learning to prioritize high-yielding billing information that fails to honorably represent the clinical work at hand during that visit. So we do see this happen as well, unfortunately, where software is being used by some companies to inflate the severity of a visit to increase revenue. Just last year, Cigna was sued, and the claim was that they had denied more than 300,000 claims in 2 months, which amounts to about 1.2 seconds per claim reviewed. And so the plaintiffs argued that this was led by algorithms. The secret was that despite a 90% error rate, so 9 out of 10 denials would have been reversed upon appeal, only 0.2% of people actually ever appeal these decisions. So there's no real consequence. Like, again, a real concern we have to highlight and address. The main reason we see these technologies really coming to the fore now is really related to, in my opinion, the potential for increased RVUs and throughput of patients, and the potential for revenue generation through the increased coding that we just mentioned. And it is, as we mentioned, really in all of the taglines for all these companies, that is a big goal. And I just worry if that's the focus, this profit-driven focus, and not the person-driven focus, that can lead to really poor outcomes in general and not realizing the potential benefits of this technology. So, we're starting to actually see this again in this article. I think it was maybe 6 months ago now. You can see this quote. Like any conscientious health policy PhD student, Paige went to the doctor for her free annual wellness visit. She checked in. The person on the front desk, the member of staff on the front desk, said something that made her anxious. Just so you know, don't discuss any problems while you're in the room, because if you do, we'll change your visit to an office visit and you'll get charged for it. That is not a foreseeable risk that I think people thought about when these technologies, which are very helpful, they're very helpful, but we had to be aware of these risks, because what can happen as a result is the cost of care can go up and people will start avoiding going to the doctor or avoiding what they're saying in the doctor because they don't want to be billed more. For older adults, there's the additional concern about care partner proxies and access to recordings. While that's really beneficial for many patients, we also have to acknowledge the potential harms. And so, for instance, there's rarely enough granularity to health record proxy access controls. And many patients simply share a password with a loved one to log in and see their health record as needed. But when recordings are available, this obviously introduces the risk of unwanted monitoring of conversations by family members and the potential for conflict. Now, again, I think that will be more on the rare side, but it is a harm we just have to acknowledge and figure out how to manage this. This can be especially an issue where cognition issues are emerging for the patient, in the case of dementia, for instance. In addition, we have to think about posthumous data use. So the risks of this data don't disappear upon death. Ensuring consent to record and transparency related to who has access to visit recordings must be regularly reviewed with patients. In the case of older adults, advanced directives related to posthumous data use should be considered, as the visit recording is unfiltered. It likely contains and retains information related to families and friends, some of which could be sensitive and protected. The patient voice can't be removed. So I mentioned about this scalable automated evaluation of the quality of communication. If we move to that and we say, well, it's not worth the cost of sending out surveys and asking patients for their opinions, it will likely be the case that patients feel less empowered and less involved in their healthcare and in the health system and giving feedback. We have to be really mindful of that. Another thing is that many of the studies that have emerged, this is a very recent review that came out, it included 18 studies, and as of June 2025, this is what the reviewers found. Ambient AI scribes showed promise in reducing workload, increasing efficiency, and decreasing burnout, but current systems still generate high emission rates. and intermittent factual inaccuracies that may affect clinical decision making. They found, for instance, that 70% of notes generated contain at least one error. The additional concern was that the evidence remains really limited to small cohorts and methodological variability, so warrants cautious interpretation. Much more rigorous standardized evaluations are really needed before we do just roll this out clinically and adopt it. But kind of the adoption is moving to that already. Another point I'll raise is you'll often hear, and you probably hear at these seminars, about human in the loop, human in the loop, human in the loop. I really don't. I'd like to know how that's operationalized at scale for something like this. But the concern, God, you'll be sick of me saying concern, because I really do care about this area, is that imagine you're a clinician, you've had 20 patients visit this day, you've had assistance with the notes from the ambient scribe. Now you're reviewing those notes. Those notes are much longer than they used to be. And maybe there's things in there that you don't remember saying. So now you're the human in the loop. Should you remove that? Or maybe you forgot to say it, and now you're questioning, what did I say? I actually can't remember. The technology is probably right. So it really puts the onus on the clinician, despite the technology potentially being the thing that's getting something wrong. It just feels like it feels a little unfair on the clinicians in this point. I also just want to mention briefly the environment, because the impact of the environment is insidious and really not felt by those who use the tools the most. And so as we develop these technologies and more roll out, we had to be really sure that they're worth the value of doing it, because the cost in terms of electricity and on the environment are massive. So for instance, data center electricity consumption is set to be more than double to around 945 terawatt hours by 2030. That's more than Japan's total electricity consumption today. There's also the emergence of these hyperscale data centers, which are massive data centers to power all of this technology, and they take up massive wealths of water in local communities. Just, I think yesterday, this was in the Guardian newspaper about a data center that's been approved in Ohio or Utah, sorry, that'll be twice the size of Manhattan. These are the real costs of adopting these technologies. So much so that companies are exploring, can we put the infrastructure for these technologies into space? This is really where it is, and these are very ingenious, smart folks trying to figure out solutions to these really massive problems. So, as I close, preparing for a future of AI-powered clinical recordings, I do want to end positively and say that there is many opportunities, but we just must be aware of the potential risks so we can realize those opportunities. We have to remember the patient is the reason for healthcare. And as the AI revolution marches on, clinicians will move from being harbingers of information to empathetic patient-centered guides on the medical journey, where we close the computer and we talk to the patient, and patient-centered skills will be absolutely essential, something that nurses have in bags. And we should partner and can partner with groups such as the Patient Revolution, that's led by Professor Victor Montori, where they can help educate and train people on how to do this well. AI applications should be guided by theory. We shouldn't just do it because we can do it. There must be some purpose for it and some evidence for it. We must mitigate against limitations that plague current AI applications, especially for older adults. Shivani, I'll mention again, has this wonderful paper. And what they found was that many of the AI technologies that have been developed today for older adults, they lack quality, they lack adequate testing, they lack adequate involvement of older adults in their design, and they result in poor generalizability of the underlying models for these tools for older adults. In fact, as many as 40% in one report of AI models developed demonstrate no or even just small marginal potential benefits compared to usual care. Do we need to be implementing all these at the cost if they're not showing really significant benefits? And I will direct you toward the Vollmer et al. Paper, which really outlines for reviewers of this work or people who are thinking about adding technologies, 20 critical questions that can help you really think through important facets of the technology you're considering adopting. I won't spend much time here, but in the Shivani paper as well, and my own group does a lot of user-centered design with older adults, and we have very standardized methods we use for this, but it really reviews quite nicely how we can engage and involve older adults in all facets and aspects of AI application development. This concept is sometimes referred to as human warranty in AI circles. So I'll let you review this in your own time. So in closing, I want to leave you these 6 principles to follow as we think about artificial intelligence in healthcare. And these were released by the WHO just a few years ago. I really like them. So one is that we have to ensure AI does not undermine human autonomy and includes patients and decisions. 2, AI technology should satisfy regulatory requirements for safety, accuracy, and efficacy, promoting human well-being, safety, and public interest. The AI technologies should be intelligible and understandable to developers, medical professionals, patients, users, and regulators with transparency, explainability, and intelligibility. There should be clear specification for what the AI tool can do and accountability for if it goes wrong. And 5, we should ensure inclusiveness and equity in the AI models. And finally, we should ensure sustainability. That's not an afterthought, but it's a critical part of the AI adoption. So with that, I want to thank you for listening. I also want to acknowledge that one of our patient partners, Roger, who had worked with me for, gosh, maybe 12 years passed last month. And, you know, we really love our patient partners and they contribute so much to us that we've missed them, and we want to acknowledge like things they do in our project and how they contribute so much to the success of our team. So with that, I'll finish and thank you for your time.
Thank you, Dr. Barr. That was terrific. We're so happy we invited you. That was a great talk. So I've used my qualitative skills to thematically analyze the questions, and they're really all falling up in the themes of ethics, privacy, the patient's right to know you're recording them, like, and then how are the recordings stored and kept safe and private. So can you talk about those issues, at least from the viewpoint of your work or what you're seeing in the actual clinics?
I can talk about it from 2 perspectives. So ambient recording and from research. So maybe from the research perspective first. In our work, we store all of our recordings on a HIPAA compliant secure server here. When we consent patients, we explain to them in our projects, and when we have our clinicians as well, that one, they don't have to have a visit recorded, even if they're on the project and they're in the recording arm. They can say, not today. At any point during a visit, the patient can pause the recording or the clinician can pause it, completely fine. And at any point after the visit, either the patient or the clinician could say, I didn't like that visit, I want to delete it, and we delete it. So that actually hasn't happened. We have people pause it once or twice, not too often, but we just want to reassure our clinicians that no, we and our patients that we so value and appreciate them giving us an insight into their lives and their care in these really challenging moments. And we want to do our best to be mindful of that. We do have a secondary consent that we ask of all of our patients, that we can keep and store those raw recordings for future research purposes. And pretty much all of the patients have agreed to that. So by the end of these projects, we're going to have in the region of about 10,000 unique visit recordings with linked longitudinal EHR data, patient-reported data. And as you know, a researcher who really believes in open science, we want to make those available securely to other members of the research community, because there's so much we can learn from that to improve patient care, rather than deleting this when we've used taxpayer money to do our research and conduct it for the betterment of the public. We want to really contribute to that meaningfully. For the ambient technology companies, my understanding is, and I don't think it's changed as of this last week, that the recordings are not available to review by the clinician or the patient. There's a transcript that's generated and maintained for a short period of time, but the transcript is automatically generated. So if there was a hallucination or an error or an omission seem to be the most frequent thing, that would not be found because you don't have the actual recording. It's just the transcript that one would have. So there is some concern about the transparency and accountability of these systems. We're in a position where we can actually start evaluating some of this because we have the recordings and we have access to visit summaries, so we can actually see how much of a difference maybe there is there.
That's good. That's good. And what about the recording devices? Like what are most commonly used, and how easy are they to use, and how clear are they? That kind of thing.
Oh, it's the development since I started doing this work about 11 years ago now is really incredible. We tend to use smartphones, like just disconnect,
Really?
from everything. But the microphones are incredible. When we use video, the recording quality is incredible.
Mm-hmm.
And as I say, we store it locally and securely. So that it's not it, it it's pretty discrete technology. It's a phone on a desk, or in our video, we have it on a little tripod.
Oh, okay. And another question about liability. So, how concerned are the clinicians about liability, and have there been any issues with recorded
So
visits?
it's a really good question. It's one I get asked a lot. And it's interesting that it's not just the clinician's concerned, it's your patients are concerned about your liability as well. When we consent patients,
Hmm.
they care so much about their clinicians. They're like, is my doctor going to get in trouble for this? Is there a HIPAA
Wow.
thing? And it's like, oh my
Wow.
God, you're so knowledgeable of these things. Well, actually, no, here, and
Yeah.
we go through it. So it's really wonderful that we have those interactions.
Oh.
Uh, but there's not been a lot of research. What the research that has been done has suggested that where visits are recorded, it could be protective for clinicians because it's a full, transparent, comprehensive record of what was actually discussed. Uh, so much so that in a case study that we conducted, we just published the paper about a month ago. Uh, the uh, a site in Phoenix, Arizona, the malpractice insurers there, they provided clinicians with a $1 million increase in coverage and a 20% reduction in premiums if they video recorded their sessions. So
Oh.
they seen it as protective.
Huh. Interesting. Wow. Didn't think about that. Wow. So you mentioned human in the loop, and I heard someone say that we really should be saying we're using um, humans with AI in the loop. What do you think about that flip?
Yeah, no, I think it's probably a more accurate way of looking at this because if you think like it's
Hmm.
one thing I've struggled with when people say, well, it's almost like a castaway comment. Well, there'll be human in the loop, and you're like,
Yeah.
let's stop
Mhm.
a second. So the doctor in the loop after meeting with 20 patients that day is that effective? And you could
Yeah.
imagine there's other what tends to happen with the technologies. And again, I'm not a data scientist, I'm not a methodologist, but I do understand that one large language model will maybe generate some predictions or could generate a report. Another model will then review the accuracy of that report, and another model will review the accuracy of that report. So the models are being used, and it is a pretty effective strategy to try to reduce errors. It's not
Hmm.
foolproof, but it seems to be like a reasonable approach. But yeah,
Mhm.
I think it's difficult to think of a situation where the human is in the loop for that sort of evaluation without assisted technologies. Uh, but there's other aspects of human in the loop. So like human in the loop in design, which means we need to have speak to our older Alice when we're designing
Yeah.
these. So we do
Yeah.
that with all of our work, user-centered design. Human in the loop with interpretation. So there's human in the loop with developing guidelines and best practices. These are things that we certainly must have, all stakeholders involved.
Mhm. Awesome. Awesome. And then one last fun question, which I've been wondering about also. Everybody thinks the webinar is excellent, lots of kudos. But the question is, what's that congrats balloon behind you for? What are you
Ah,
celebrating?
I, 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 it's just for myself. I come in, I just want to feel like, congratulate myself every day. No, I, I was recently promoted to full professor, and
Whoa.
my team had a nice celebration for me, and one of the PhD students blew up this each letter of
Oh.
congrats, and so I feel bad taking it down or deflating it because he spent so much time blowing into it. I was like, I'll just keep it there until it goes away. So
That's
it's been two
great. That's
months and it's going
great.
pretty strong.
Oh, sorry we missed that. I introduced you as
No,
associate
no,
professor.
it's totally fine. Don't worry.
All right. Well, thanks so much. Well, thank you to the audience. The recording is going to be shared on YouTube next week. And then we're going to return on Thursday, June the 11th at noon for our final webinar of the Year 4 series. And our next speaker is Barbara Barbosa Neves, and she is a PhD prepared scientist from the University of Sydney. And again, June 11th, and her talk is going to be on automating ageism, AI, care, and aging futures. So we hope to see you all there. And Dr. Barr, it was a pleasure meeting you and hearing of your important work. So good luck to you.
Thanks so much for listening.
Thank you. Bye, everybody.
Bye.
Have a good weekend.